like I was just wondering, you know, one of the major problems is beds in hospitals and their availability. So what is your party doing just to directly address that problem?
Yeah. So so what I've been hearing from my party repeatedly is that the hospital, this idea of like that our money goes to hospitals as these big facilities where healthcare happens, that it's time we have to move away from that model. That is not necessarily the most cost-effective model or where we should be putting our resources. So we have to start creating like a community-based model. I think the Sherburne Health Center is a great example here. I think the Women's College Hospital was a great example of it as well. But they can be much smaller, much smaller scale models, where we have sort of like, you know, hubs of healthcare in different spaces. And so that might mean that, you know, current facilities are transformed in those spaces. It could be an expansion of those spaces. We don't envision more hospitals. We don't envision more hospitals. We envision, you know, communities, like healthcare communities, where people are working together. Because a lot of times people go to their doctor, the family doctor, for an issue that's really, you know, around mental health, right? Or something that's around nutrition, or something that is around, you know, maybe muscular needs. So there's a lot of pieces, and the doctor becomes, the physician becomes the primary point, and they often have to refer, right? And so it's very wasteful time for a highly skilled profession. And so we want to make sure that there's a community model approach.
In most of the research, only about 1 in 1,000 Canadians would end up in a downtown teaching hospital, and somehow that's the focus of our medical education. And we've got to get much more experience out in the community, and we've got to keep. I mean, and that's what Women's College is now dedicated to do, is to keep people out of hospital. I mean, I mean, at the moment, I mean, my upset is, I mean, that you come to hospital and get you know, some sort of, you know, hospital-acquired infection just seems like ridiculous that we actually continue to allow that in our country. In the kind of transformation that requires hospital to community care, in some ways, when my accidental tourism in politics was the fight for Women's College Hospital, because we were already doctored interdisciplinary hospital to community patient as a full partner, and we thought that should be the model of the future, and we didn't want to get married to somebody who was doing it the old-fashioned way. That being said, before we can negotiate the 2014 Accord, we have put in place this family care plan that has been hugely well received by the palliative and compassionate care people, which would allow people to take 6 months off work to look after a family member who's sick or very sick or dying at home, such that they could use EI to be able to do that in little pieces or by 3 or 4 different members of the family. But I think it's going to be this bottom-up community-based care that's going to demedicalize what is actually just compassionate care and get us a much better quality end of life.
Next question. There's one over there in orange sleeves.
So I was wondering, I think it was casually mentioned, but we haven't actually talked at all about EMRs yet. And I was wondering what each of your parties are planning to do with, I mean, there's a lot of talk about instituting it everywhere from individual family practices all the way to hospital-wide systems, but I kind of think the cat's already in the bag, people are instituting private systems, so what do you plan to do with this plan?
This is a question for everyone or for someone specific? Everyone. Okay, so why don't we can start with Dr. Wilcock.
Electronic medical records are essential for providing safety-based care, but also more efficient care. And anyone who's worked in healthcare knows what it's like in Emerge. You're trying to find, if somebody says, oh, I had an ultrasound yesterday, and you can't get the results. They say, oh, I'm on this medication, but I don't know what it is. And without electronic health records, which are universal and I would say should be transferable across Canada, we will continue to have medical errors, problems, and waste in the system. If we can have a universal electronic medical record, and possibly we all carry a smart card. My parents live in France. They have had a smart card for years. They go to the pharmacy when they buy drugs. The pharmacist knows exactly what they're on and what their allergies are. And they've had this for 15 years. I don't understand why Canada is so behind.
But how do you convince systems who have already adopted private and paid for private systems to change to like a new, like
How do you mean?
You have an extra 30 seconds of your minute and 30 seconds, Dr. Wilcox.
Like there, what I
Yeah.
think about hazardous bags, like there are already individual practice groups and hospitals that have paid more and taken on a private EMR system. So like,
They're not exactly paying for them. Take it from me, I've got EMR in my office. They get paid for them. We get a payback from the government right now. So don't let anybody tell you they've
but
bought.
they're paying students to transfer all their paper data
They
to
don't.
the system.
That's the cost of running your office has always been that, we need it, and I think if you legislate it, it will happen, and that's what we need, and it's necessary for patient safety.
Michael, did you want to comment on the EMR?
Well, here's the part where I'm a teacher and not a doctor. Okay, and this is a very specific question, so I don't actually know what my party's.
You're for it.
I'm for it. I mean, so I'm going to speak into general terms what I do know. So, but it might not address your question directly. So, we are of course into electronic medical records. It does tie in very closely with our piece around pharmaceuticals and what's happening in pharmaceuticals. The other part of healthcare costs for individuals is the cost of drugs and medication. We know that one of the things we're pushing very clearly is we want to make sure that practitioners are prescribing the correct medication based on scientific evidence and research. And some of the folks out there haven't updated their own knowledge base around those pharmaceuticals. And we also know that people get kickbacks, right, from the pharmaceutical companies as to what they're referring to. So we want to make sure that, in an electronic system, there be more clear and transparent and updated information when it comes to medication, so that maybe some of these profit motivations might take a back seat to good medical care.
Okay, Dr. Bennett, you have a minute and 30 seconds.
At the beginning, we did, I think, fall into the trap of vendor-based systems, and everybody thought they knew better, and we just have to quickly leap into interoperability between the systems that exist in web-based solutions, and I think that's possible. I think that we also can insist in patient safety, that people should, in Cuba, they know how many smokers in your practice, how many obese, how many lipids out of control, how many hypertension, how many sedentary. That if we were asking for these kinds of epidemiological reports, people can have students combing their charts all summer, or they can put in place the kind of system that they will need to be able to generate the kinds of reports that we will find out in terms of the actual social contagion of diabetes and these things where we are going to need to invest money in those programs. So I think that we have to get on with it. The Veterans Administration in the United States went from the worst healthcare system in the U.S. to the best in 10 years, beating Mayo, Kaiser, everything, just because they had a closed system with one set of electronic data. It deals with forgetfulness, it deals with allergies, it deals with all of these patient safety problems, and giving prompts and the alerts and reminders come from my dentist and our vet. We are a decade behind the vets and the dentists in terms of reminding people to
Don't
come
go
in.
there, that's private.
Next question. There's one over in that corner, and then we'll go to the middle and then back to the edge. Okay?
Hi, I just had a question. You mentioned Kaiser, so my question is kind of along those lines. So the Kaiser Hospital, I'm sure you guys know, has done a really good job at keeping patients out of their hospitals. They're focusing on preventive care. That's the sort of mantra of their system, and it's working really well and saving them a lot of money. Is there a way for the federal government to put some sort of program in place, change the Canada Health Act, whatever, to incentivize the provinces to put that same kind of emphasis on preventative care and keeping patients out of hospitals?
This is a question for everyone?
Yeah.
Okay, so why don't we start with Michael?
Sure. Well, the way that I understand it currently is that, the NDP, we propose a series of acts and policies we'd like to see in place around preventative healthcare, medicine, and education programs. So I'm unsure whether or not something to that degree could be enshrined in the language of the 2014 Accord. But of course, we do know that preventative care is key and education is key.